Hi, my name's Erin Elbel, and I'll be presenting our abstract, Clinical Characteristics and Short-Term Outcomes of Children with Asparaginase-Associated Pancreatitis. Asparaginase is a chemotherapeutic agent used in the treatment of acute lymphoblastic leukemia. Asparaginase-associated pancreatitis is both a common and often dose-limiting toxicity of this drug, with significant short and long-term complications. Recent evidence suggests that asparaginase may predispose to a more severe phenotype of pancreatitis than is seen with other causes of acute pancreatitis. Our aim was to describe the short-term clinical course and disposition of patients who developed AAP at Boston Children's between 2005 and 2015. This was a retrospective descriptive analysis, including 34 patients with a total of 43 separate episodes of pancreatitis. Chart review was by analysis including abstraction of laboratory data, ICU days, ultrasound and CT findings, and presence of systemic complications such as signs of end organ failure. Statistics were carried out by a biostatistician, and we obtained IRB approval. The diagnosis and severity was based on International Study Group of Pediatric Pancreatitis in Search of a Cure, INSPIRE criteria, and the Atlanta criteria. Our patient had a median age of 8.3 years with a range of 2.9 to 18.2 years. The population was 44% female and 55.9% white. The inpatient length of stay in the median was 10 days with a range of 2 to 65 days, and there were 0 reported fatalities within our case series from acute pancreatitis. We classified pancreatitis as severe if the patient developed pancreatic necrosis within 1 week of diagnosis or developed signs of end organ failure, including hypotension or pulmonary insufficiency, or required ICU admission. 16.3% of patients did require ICU level care, and a total of 39.5% of patients were classified as severe. An additional 39.5% of patients required TPN. 46.5% of patients were treated with antibiotics. Of note, antibiotics prophylactically are not recommended by either our institution's clinical algorithm for acute pancreatitis nor by NASPGHAN. So this likely suggests clinician concern at the underlying immunocompromised state of these patients. Finally, nearly 30% of patients demonstrated pancreatic necrosis radiographically via CT or ultrasound within 1 week of clinical diagnosis of pancreatitis. This CT of a patient with AAP demonstrates ill-defined areas of hypoattenuation within the body and tail of the pancreas consistent with pancreatic necrosis. In conclusion, nearly half of patients develop severe pancreatitis based on presence of necrosis or systemic complications. The prognosis of AAP is generally good with low mortality, but many patients do require TPN, antibiotics, and ICU level care. The limitations of our study is that it is retrospective, single center with no long-term outcomes, and no validated system yet exists for classifying severe pancreatitis in children. Therefore, we relied on the adult Atlanta criteria as well as the INSPIRE criteria. Future directions include the algorithms to predict which patients may have a severe course from AAP and establishment of a prospective registry for all comers with AAP. I'd like to thank my co-authors and thank you for listening.